the Survivorship program at the University of Illinois. And she is going to speak with us about promoting the prevention and early detection of cancer through universal hereditary cancer risk assessment, and sharing with us their preliminary findings. Thank you, Dr. Dept.
Thanks. You guys hear me okay? Coming. Let me know if not, I can switch. Okay, so before I get started, I know we've lost some people and people are having snacks and things, but I wanted to just get a show of hands. How many people in here have been to their primary care doctor in the last year? Go ahead. All right. No. And how many people, when you went to your primary care doctor, how many of those doctors asked you if you had a family history of cancer? Okay, but really, like, we just went in half or maybe a third. Okay, and of those who asked you if you had a family history of cancer, did they tell you whether or not you were eligible for genetic testing? Hands up if they did. Not a single one in the room. Okay, so we got a lot of work to do in the primary care space, right? This has been recommended for over 20 years and it's still not happening in primary care. So what I'm going to talk to you about today is just, I'm going to share with you some preliminary results from 3 ongoing projects that we have to really address this in our federally qualified health centers that are affiliated with our institution. You know, I think this isn't happening. It is happening in some primary care spaces, but it's probably in the majority of them not really happening at all. And we really wanted to see sort of what was going on in the FQHC space and how we could help make this happen, how we could start to implement this and bring these services to, especially to our underrepresented minorities. So that's what I'm talking about today. I am an oncogeneralist. I do all my work, all my clinical work in our federally qualified health center. So I'm a clinician. People call me an oncogeneralist, although most people have never heard of that term. It means I sort of take care of patients on the cancer control spectrum, sort of on the edges. So on the cancer prevention side in genetics. So I do a lot of my work in cancer prevention and genetics. And then I also do a lot of my work in cancer survivorship. And then I'm the director of cancer prevention and survivorship at UIC. I spent 23 years prior to coming to UIC at Cook County Hospital, which is the big safety net hospital in Chicago. So a lot of my work has really been dedicated to trying to bring cancer genetic services into to our vulnerable populations through the health system. Okay, let's see. All right. So the 3 projects I'm going to talk to you about today have all these funny names with the MI, and I'll tell you a little bit about why, but we pronounce that MI. So I'm going to talk to you about MyFamCam, the Test My Genes, and our what we call the CSTAC projects, which are all really focused on bringing equity to genetic testing access through universal hereditary cancer risk assessment. And then also through a kind of evaluating train the primary care provider to provide point of care testing in primary care. And then the third project is really more about conducting an environmental scan, like I mentioned, to sort of see what the state of FQHC's implementation of this is around Chicago and the Chicagoland area. So those are sort of the 3 projects I'm going to talk to you about today. And just as a background, I think we all know this, so I'm going to go through this really quickly, right? But family history screening for hereditary cancer syndromes has been a recommended evidence-based practice for over 15 years. Next year, in 2025, I get to say 20 years. That's a long time, right? This has been recommended by the USPSTF since 2005. Nonetheless, over 80 to 90% of people with a genetic mutation that predisposes them to a hereditary cancer syndrome really are unaware of their risk. And we know that there are known racial, ethnic, and socioeconomic disparities in both the access and the uptake of genetic counseling and testing. And I think we've talked about some of that today. And implementation, as evidenced by all of you and voting with your hands, is really lagging in the primary care space, right? So, and that's due to a lot of different reasons: limited staff and resources and time, limited genetic counseling workforce, and limited clinical decision support in our EMRs. And so the projects that I'm going to talk about today are really focused. I'm sorry, am I coming in and out, or am I okay? I am. So are really going to focus on some of the barriers to testing that we've experienced in our clinics and try to evaluate potential strategies and come up with solutions to really change this, the landscape of this. So the barriers to testing, I think many of these we know and I mentioned, but lack of equitable access to genetic testing. And the way that we are sort of addressing that is through implementing initiatives in an FQHC system of clinics. So really trying to figure out how to do this in low resource settings. So if we can figure out how to do that, we should be able to trickle that up, right? Rather than figuring out how to do it in really high resource settings and then figuring it out kind of backwards. So And then I think that a lot of what we are doing in our projects is trying to address provider bias and disparities in referral rates for minority populations. So we know that's out there. I mean, providers aren't doing this for a lot of reasons. They're short on time, right? They're not knowledgeable, but they also, there's a lot of bias, sort of, hey, I don't think my patient would really want this. And that's not really their decision to make. So trying to really implement sort of a universal approach to hereditary cancer risk assessment. Lack of provider knowledge, I mentioned, so we've developed, through our work, we've developed a lot of provider trainings, also electronic tools and clinical decision support tools. And then I think that a big part of our research is to really look and examine different models of care that can leverage point of care testing and leverage that trusted relationship with the primary care provider to try to improve that uptake of testing in our populations. And then finally, really thinking about how do we do this on a scalable and sustainable way, right? So and as I'll talk about, we're utilizing implementation science research to evaluate alternative care models, that point of care testing, and then to conduct an environmental scan to sort of understand what's happening in other FQHCs and how we might take our lessons learned out to those FQHCs. So the three big initiatives that are underway in our primary care, as I mentioned, number one is really embedding that universal risk assessment and clinical genetic services into our FQHCs. We call that MyFamCan. Again, hold tight. I'll tell you why we call it mine in a minute. Number two, training a primary care workforce that really can help us bridge disparities in access and uptake and sort of not take away what the genetic counselor is doing, but take that front end piece, that education. This is what we do with a lot of different screening tests, right? We're very comfortable as clinicians for doing that. And I think that we can help scale these services by really trying to take off that piece of it, that front end piece. And then finally, implementing and evaluating multi-level solutions to address challenges to scaling and sustaining these services through the project that I'm going to refer to as Test My Genes. Okay, so our vision is that we have universal hereditary cancer risk assessment system-wide across all of our FQHC clinics, and that all adult patients that are seen at the Miles Square Health Center clinic, to give you a clue to the MI, will receive a family history screen for hereditary cancer syndromes at least every 1 to 2 years. Remember that family history is dynamic, right? I can come in and see my primary care provider. You could have seen them this year and next year. Maybe your sister gets breast cancer or your brother gets prostate cancer. Family history is dynamic, so this isn't a one-time thing. But as clinicians, it's sort of, we're taught to do that at the first visit, right, as part of the full H&P, and then it's really not part of our process to update that regularly. So this is sort of trying to make sure that we get this applied universally and that we're doing it on a regular basis to make sure that we're getting updated information. In addition, guidelines change, right? So the other reason to do this is not necessarily because family history is changing, but guidelines might be changing in terms of who's appropriate for testing and eligible for testing. And then finally, you don't want to do any kind of screening unless you have, the back-end management. So making sure that we're appropriately connecting patients to individualized risk management services is another big part of this quality improvement project that we're doing across our clinics. Okay, so here's the MI, all right? It stands for Miles Square, so MyFamCan and Test My Genes. And these are the 6 adult serving federally qualified health centers on the right. So they're spread throughout Chicago, really in some of our most, our neighborhoods that serve some of our most vulnerable patient populations. So the south and the west sides of Chicago. We also have a clinic up in Rockford. We have not implemented any of our initiatives there yet, but that's our hope, is that we get across all 7 of them. Okay, so I'm going to start with the MyFamCan project, then I'll talk about Test My Genes, then I'll talk about the CSTAC project. So in terms of the MyFamCan project, as I mentioned, we are screening all adult patients who are 25 and older who present for a routine primary care visit at our FQHCs. They get this done electronically through an electronic family history questionnaire via tablets that are in the clinic and administered by navigators. Now, our goal to sustain this is to move from the navigator model to the MAs doing this, because as some people mentioned this morning, right, you want to do a research project, go in there, say, hey, we can do it, and then leave. So the goal is really that we bring navigators in to sort of get the process going, and then we hand that off to the clinic staff. The purpose is to identify patients at high risk for hereditary cancer. We also do some breast cancer risk assessment in this, and we've also launched this in our mammography center as well. And we also brought into this survey and this risk assessment a health literacy screen to sort of determine who those navigators need to spend more time with, right? So some patients can self-administer this, but others really need assistance to get good and accurate information. And right now that health literacy screen and that whole risk assessment is taking about 3 to 5 minutes per patient, a little more for those on the low health literacy and versus those on the higher health literacy. And I'll show you some data at the end. Okay, so this is the impact of universal hereditary cancer risk assessment at my FamCam project on access to genetic services since we've implemented. And this includes our primary care centers and our mammography center. But you can see that to date, we've screened about 6,000 patients for risk assessment for hereditary cancer syndromes and identified about 1,800 as eligible for genetic testing. And we've seen about a 3-fold increase in referrals from the FQHCs where this was implemented compared to those clinics, right, that have not had this implementation. They've maintained similar rates. So we're seeing a real increase in the referral. Preliminary findings here, we've detected about 6 positive findings on genetic testing, but that's really early data. We're still looking. A lot of these patients haven't gotten tested or we haven't gotten the results back. So I think that number is going to change. In general, we think about genetic testing for cancer as sort of a low yield, high value test, right? So kind of like mammography, right? Or Hep C screening. We're not going to find a lot, but when you find it, it really changes the management of your patients. In terms of evaluating the impact on equitable access, so you can see here the characteristics of patients who are undergoing universal hereditary cancer risk assessment in our FQHCs. 90% are Black or Hispanic, 50% are under the age of 50. 25% are male, and about 10 to 15% have low health literacy. And I think these are important for many different reasons. I think it really does show that we are getting these services out to the populations that have historically been left behind in some of these initiatives, especially when there's new tools and new testing that becomes available. I think the other thing in terms of picking young patients, it's not me, I promise. Okay, so maybe it is me. Is it echoing? Okay. So, a lot of the hereditary cancer risk assessment that has been implemented in institutions has been implemented in the mammography departments. But that usually picks up patients when they're 40 and older, and it misses men, right? So I think it's really important to get these services into the primary care clinic because we're reaching younger populations and we're also reaching men. All right, so this is a subset of those 6,000 patients that we, in the 2 of the clinics that we launched at initially. I just want to sort of show you the uptake of cancer genetic services so after we identify patients, what happens to them along that journey, that patient journey? And so this is a subset of about 1,300 patients that underwent screening in 2 of our clinics. 276 were identified at high risk. And you can see at each point along the way, right? So after the family history screen, we had about over 20% who weren't referred. And this wasn't because they didn't want it. A lot of this was providers forgetting to refer, not remembering, too busy in clinic. But of those who were referred, about another 30% were not scheduled. So we're seeing big drop-offs at each point. This isn't just get a screen and get a test. And that's maybe what we need to move to. So I'm going to talk about that in just a minute. But you can see drop-offs of about 20 to 30, over 30% at each point along the way, right? Patients getting scheduled, but then not ever being seen, not showing up for their appointment, attending a GC appointment, and maybe that was a telehealth appointment and the GC sent them a saliva kit in and never comes back. All right, so essentially, only about 23% of patients who are interested, who actually screen positive as eligible for testing, actually make it all the way through to testing. Okay, so the second part of, and the research that we're going to do is now going to be evaluating, and I think that Dr. Hamilton's going to talk about this next, so I'm not going to talk a lot about it. I don't want to spoil the show, but just, so what we are doing right now is starting to evaluate the impact on uptake with a different model of testing, that's point of care testing. So basically taking that person from the family history screen right in that primary care clinic to teach their primary care providers to do that testing themselves. Okay. So this is the research that we're doing. We're funded by the American Cancer Society, and it really takes advantage of this MyFamCam project to allow us to compare what happens in terms of the uptake of testing among those patients who sort of go through the referral model versus those who go through the mainstream genetic testing model. And we're training our primary care providers to do this. And we're evaluating both the implementation outcomes of acceptability, feasibility, and sustainability, as well as barriers and facilitators, and then looking at the effectiveness of the 2 models on the uptake of genetic testing. Okay, so this is a brief study overview. I'm not going to spend a lot of time on this. We chose the EPIS framework to really guide our process. gathering our partner feedback at the organizational, the provider, staff, and the patient level. And then we started the study in the preparation phase. So you can see in that first box, we started in the preparation phase because, as you can see, a lot of that early work had been done by our team in terms of identifying some of the determinants, the barriers. And then the measurements occurred at different time points throughout the study, and we used qualitative measures to look at and evaluate our implementation outcomes. We are now in that red box in the implementation phase. Right now, we have both models running at several of our clinics, and we're conducting patient and provider interviews and measuring the uptake of genetic testing. So we're kind of nearing the middle of year 3 right now. Okay, a little bit about provider training and support. So we conducted provider trainings for about 2 hours. So this wasn't really intensive in terms of the lift for providers. We included, based on feedback, a video demonstration of how to talk with a patient. And we made it very clear with providers, you don't need to replace the genetic counselor. This isn't a 45-minute detailed family history and long genetic counseling session. This was really something that you can do in 2 or 3 minutes. And those patients who need more information could still be referred on to a genetic counselor. We also, I think it was really important that we implemented some EMR tools. Importantly, the the test ordering. So if you can't order the test in your EMR, you are looking at a whole lot of paperwork to get this done, and our providers are like, no way. So also smart phrases for documentation of the conversations, and then coming soon, some of those family history screening tools I told you that are electronic, that we're doing with an external system, are going to be integrated into our EMR. But that's not there yet, and it needs to be. We also developed patient and provider handouts. They asked for this. So providers wanted a little piece of paper that said, what are the bullets I need to go over? Can the patients look at those ahead of time? And then remind me how to order the test, right? If they're not doing it all that often, they're not remembering how to do this. So so just sort of walking them through that. On the right are sort of the handouts that we developed that we gave to patients and to providers. And so it sort of walked through, some of the basic questions to make sure that those were covered, and then additional information, including insurance coverage and life insurance and things that patients sometimes have questions about, to help providers be able to answer those. The other big, issue that comes up a lot with patients is cost. A lot of providers have a lot of misconceptions about cost too. So this educational sheet really worked for both patients and for providers to learn more about this. So here are some really preliminary. I did say this is all preliminary. So low numbers here. Our referral model was implemented first, and then we started with our MGT model. So in this table, you can see that in that second line, right, there's 276 patients that I mentioned to you that were identified at high risk. 64 were tested, so a total of 23% in terms of the uptake of testing. And it took almost 3 months to get them through to testing. With the MGT model, again, really small numbers here. First 20 patients, 12 have been tested for an uptake rate of about 60%. We're starting to run some of our additional data on that. It probably looks a little bit lower, but it's definitely higher than what's happening in the referral model. And then importantly, this is happening right at the point of care. So the time to testing is pretty short. Not everybody does it the same day. Some people come back and do it at another visit, but we're getting that testing done a lot faster, which I think is preventing some of the drop off. So post-implementation outcomes our preliminary outcomes from some of our qualitative data. So we did semi-structured interviews that were conducted and recorded. We did this with 7 out of the 10 providers that got this. Again, these were the first 2 clinics we implemented in. And they were all getting that referral model. They weren't doing MGT, but we did ask them questions about what they thought about MGT and whether they'd be willing to do it. Our content analysis is underway. And the potential themes that we developed from the topic areas in our coding framework include acceptability of HCRA and the models of care, feasibility, sustainability, provider training needs and satisfaction, and barriers on the provider and the patient level. And these are just some of the recurrent themes that we're finding. So overall, the universal hereditary cancer risk assessment and the referral model were considered very acceptable and feasible, with that navigator assistance for patients and providers. And providers were very satisfied with the training in the referral model, but they said, we're going to need more time and more training to be able to do this ourselves. There was a lot of concerns about whether the universal hereditary cancer risk assessment would be sustainable in clinics that didn't have that navigation support, just because a lot of the MAs, and we were seeing it while we were there, they were turning over, right? They didn't have enough in clinic to even cover all the docs, let alone hand a tablet to a patient and walk through it with them if they had low health literacy. The main barriers that were cited by providers were that they were forgetting to place the referral for their high-risk patients. They're in really busy clinics seeing sometimes 4 patients in an hour, right? And then the providers also said that patients don't always know their family history. It's not right. They're like, well, mom had stomach cancer. Was that the ovary? Was it that the pancreas? Was that, so a lot of sort of, I'm not sure what that is and whether they meet criteria based on that. And then as we saw in that drop off, making and missing appointments. We also looked at some workflow implications. So our primary care providers were like, you can't come in here and do this in the clinic. We can't take this over unless this is happening really fast. Okay, they told us we had to do it in 3 minutes. I'll show you where we got to. But this is also, I showed you this diagram just to show that, part of the idea with bringing navigators in to do this for the first 6 months is that you're getting a lot of the patients screened so that when you transition this to the clinic staff, those patients that are coming back don't need to be screened for another year or two. So that volume really drops off after about 12 weeks. So it looks like, I think that this is potentially sustainable. We're starting this now with a couple of clinics where they're taking over from our navigators. But after about 12 weeks and definitely after 6 months, those numbers are dropping off. And then in terms of workflow implications, so they told us 3, we got it to 4, which is pretty good. And they actually said that's not bad. So they are starting to consider doing this themselves, and one clinic is doing it. Takes a little longer for our lower health literacy patients, but not that much longer than with our high health literacy patients. So times are pretty good and pretty close to target. Okay, so summary and lessons learned to date, just from our MyFamCan and our Test My Gene study, is that I think that universal hereditary cancer risk assessment is feasible and acceptable to both patients and providers, even though they aren't really doing this around in primary care in general, but it is feasible and acceptable. It does increase the identification and referral, especially of minority high-risk patients, by about 2 to 3-fold, and it has minimal impact on workflow, with the highest volume really in the first 3 months. And then in our Test My Gene study, I think we found that leveraging that trusted relationship with a trained primary care provider to deliver point of care testing with that genetic counseling back-end support is also feasible and acceptable. But provider education alone is not enough. Our preliminary data, and I hope to come back here next year and show you our data that from all of our clinics and our more mature data. But it does suggest that there is an increase in genetic testing uptake with mainstream testing. And we'll be examining harms. So a lot of our interviews are focusing on what the potential harms are by having this done by primary care providers. It's a big concern of our genetic counselors is that primary care providers are just going to say, hey, you should do this test and not really help patients make an informed decision around this. And we'll have implementation data from our additional 3 sites. Okay, I'm going to just switch real quickly to the third project and our prelim findings from this project. So this was the environmental scan that we did to assess the readiness and capacity for hereditary cancer risk assessment and genetic cancer service delivery to vulnerable populations around Chicago. So outside of our FQHC system. That was one of the systems that we did our scan at, but we really spread this out to we tried to hit all of the FQHCs. So we developed a 21-item survey and sent that to the CMOs at 22 federally qualified health centers. So a center could have a number of clinics within it, which is why we sort of went to the CMO level. So there's a lot more FQHCs around the Chicagoland area, but we tried to bundle them by and went with the sort of leadership of each clinic. And in that survey, we wanted to assess current practices, readiness to implement, and potential barriers to hereditary cancer risk assessment. Paralleling that, we also did a cancer genetics capacity survey. So we developed a 25-item survey that we sent to 21 cancer genetics service sites. So a lot of teaching hospitals and some of the outlying hospitals that had cancer genetic services around Chicago. And this was more like looking at capacity, right? So looking at readiness for FQHCs to actually implement something, and then looking at our capacity of our genetic counselors, resources to be able to handle, something like universal hereditary cancer risk assessment. And then to look at referral patterns and potential barriers to access from the GC's point of view. All of the surveys were administered electronically, and we used descriptive statistics to analyze our survey data. So our survey completion rate was actually pretty good. So for our FQHCs, we had a 95% completion rate. There's a little incentive there. We offered to, buy the clinic lunch from the CMO, right? So the CMOs who would complete it. Our cancer genetic clinic sites a little bit lower, but still really good. So 86%, so 18 sites participated in that survey. This is a summary of our FQHC survey results. So you can see here that the majority of them reported familiarity with the USPSTF guidelines. we may not have asked that right, because when we started actually digging into some of this, they were like, yeah, well, that's the mammogram. Like, no, this is the genetic test. So I'm not sure it's really as high as what we found. We may not have asked this the right way. 25% of them reported implementing some form of HCRA, but nobody was really doing it at the time. And there were 75% said they had no plans to implement this at all. 65% had not yet assessed staffing and resource needs to implement this. And I think that most of them identified workflows for how to administer this, a considerable challenge. Okay, so this is using a 4-point Likert scale. We assess the significance of each listed barrier to implementing family history screening for hereditary cancer risk assessment. And the results are the barriers perceived by the CMOs as moderate to significant at the FQHCs. And so if you look on the left, right, the two left-hand columns are really reflect resource limitations as our top two barriers, right? So clinic workflow and resources for referrals and follow-ups, and really challenges incorporating family history screening into those workflows. And then in addition, on the next bar, the third bar, perceptions are really, I think, misperceptions about high cost. The cost of genetic testing has come down significantly. It used to be in the $1,000 to $2,000. And a lot of providers actually think it's still really that costly. So that's why I call that a misperception. And then along with our last two columns on the right, perceived lack of clinical actionability and lack of provider knowledge, I think those four could really be addressed through training, right? Through provider training and awareness. Clinic workflows are going to take a little bit more time, but we have showed that it's feasible. I circled the fourth bar, because I think this is a really interesting one. So not having a UDS or a HEDIS measure. How many people know what a UDS or HEDIS measure is here? Okay, so these are really metrics that are used for health payers. So 90% of health payers really use these to sort of understand what we're doing in terms of quality performance with chronic disease, and they're tied to reimbursement. These are accountability measures. All right, and I think that the take-home point for me here, and I think this is a big one, is that we can have all the evidence-based guidelines we want, but until we have accountability measures that actually really make us do what we need to be doing in the clinic, we're not doing it. It prioritizes what the clinic focuses on. Okay, so now you could say this for everything that we all want to do here, and we're presenting today. So you can't have like a zillion accountability measures, but I think that, you know, it does help to sort of prioritize this. And I think if there was a menu that clinics could pick from in terms of like what they should be working on, what they might want to work on in the future, that might be another way to really promote the adoption of these initiatives. Okay, so takeaways from our FQHC survey is that in general, not a surprise, hereditary cancer risk assessment was not being done in most of our FQHCs. None of them had really thought about a timeline or assessed resources. But in terms of the barriers that they cited, the majority of them can really be overcome through training and through referral partnerships. Okay, what about our cancer genetics capacity survey results? So in general here, I think what we realized from these surveys is that there's more capacity than we thought. I mean, at my institution, it's 6 months to get an appointment with a genetic counselor, but that's not true at every institution around Chicago. So 40% of our sites, our genetic counseling and genetic services sites, reported wait times of less than 14 days. That's really good, right, for a new non-urgent appointment. A lot of them are triaging, but this is for new non-urgent. 50% of them reported they were not at full capacity. Again, reassuring that if we were to do something, if we were to implement something like universal hereditary cancer risk assessment in an FQHC, there is a back-end support to actually get those patients seen, at least through a referral model. The sites identified logistics, lack of communication from referring providers, like the patient was sent to the genetic counselor, obviously for a family history, but it wasn't listed and the patient didn't really know why they were there. Right? So a little bit of confusion there, miscommunication. And then understandably, genetic counselors expressed concerns for harm. So we said, what do you think about primary care providers doing this themselves, right? Doing this with different models. And they were concerned, understandably, about misunderstanding or lack of information for patients to be able to make informed decisions and the anxiety around that. So again, here is listed the barriers. You can see that the most common barriers were most frequently cited barriers among the genetic counselors who were asked were lack of referring provider communication, systemic racism, which I think reflects a lot of provider bias. So they were seeing this too and reporting this. logistical barriers, and then some things related to insurance and high out-of-pocket costs, which may be related to genetic counselors actually being at institutions that don't accept some of the insurances for the patients that they want to see. And then low health literacy. Okay, so takeaways from the genetic counseling survey is that there is capacity in our teaching hospitals for expansion of genetic services if we were to do these initiatives. And I just walked through the perceived top barriers, so I'm not going to repeat those again, but I think that genetic counselors are concerned about the harms from testing, and we need to explore the harms from testing if primary care is going to take this on. So how do we bring all three of these project findings together? Universal hereditary cancer risk assessment increases the identification of high-risk patients in primary care. We've shown that, we know that. Not a surprise. But genetic services are really currently underutilized in primary care, and there is unused capacity. Our FQHCs do need support and connection with cancer genetic resources in order to implement a hereditary cancer risk assessment initiative. I think that our research demonstrates that universal hereditary cancer risk assessment implementation into our FQHCs is feasible, but may require temporary or ongoing navigation support for sustainability. And that our preliminary results suggest that our MGT model can increase the uptake and scaling of genetic testing, but we still need data on acceptability and harm. So I just want to end with, doing okay? All right, end with us rethinking innovation and research priorities in safety net settings, right? So most everybody here is a researcher, right? What is the right type of research we should be doing in our safety net settings? And I think innovation is not always the priority, right? And so what's that, and going back to what you said this morning, what's that right intervention, right? When's the right time for it? What's the right population? And what's that right innovation in our safety net settings? And when is the right time for innovations to be implemented in safety net settings? I think implementation science research is really key here, right? We can identify small scale innovations, little things that have potential for larger downstream impact. And we need to think about that research as sort of like allowing those clinics to internally develop customized solutions that can really promote adoption, improve acceptability, and really increase leadership involvement to promote adoption. And then, I think that this type of research can really allow time for integration planning, for identifying those barriers and facilitators. So I would encourage all of you, if you haven't thought about doing research in an FQHC setting, because there's not a lot of research happening in these settings, to think about that. I think that it's ripe for a lot of research, and I think that research can really improve the quality of care provided. So these are just the committee members for our CSAC group that is funded by the Susan G. Komen Foundation. This is our MyFamCan implementation team at UI Health with my genetic counselors and a couple of clinicians and nurses and research associates. And this is our Test My Genes study team. So, I will stop there.
Thank you for that great talk, Pamela. Do we have any questions? I'll start with one. Just hearing you speak, it's making me think about a 2008 paper where they said that one of the key factors for primary care physicians referring patients for genetic services were the patient populations they serve, with differences on the proportion of minority patients, patients without insurance, patients on Medicaid or Medicare, and patients that didn't speak English as a first language. Did you see any differences among the PCPs in your study? Did you guys look at that?
Yeah, so we haven't looked at that yet. So again, this is all prelim. What we were able to look at is the table where or the data I showed you in terms of who are the populations that the clinics are seeing. And we broke that down by race, we broke it down by insurance, and then we looked at the same thing in terms of who was referred, and they pretty equally matched. Right, so I think that the universal approach is really helping overcome some of the bias in referrals. You're next.
Hello, thank you so much for presenting your work. This was really cool to see, especially coming from Georgia, where we do have a statewide screening program. But given that, we do have some public health clinics that have been holding out in participating. And without saying too much, right? Like sometimes they just feel that there isn't a lot of value in early cancer screening that has to do with hereditary cancer. So do you have any recommendations for how to convince them that this does have value for patients?
some of it is because, well, but you get so few positives tests, and it's like, oh, they're just all negative. Why am I doing this? But it's like that one, right? You have that experience with that one patient that has, that positive test and how that impacts their care. And maybe having those patients come and talk to, coming back to our sort of community participant-based research, right? Having some of those community leaders, patients with lived experiences, right, with this, and having them sort of talk to those organizations that aren't doing this to sort of share that value. And then setting that expectation. It is a low yield, high value test, right? But that one patient, can make a huge difference in. So I think there's other strategies too, but that's the one that comes to mind. Yeah. There was a question over here.
I have a logistical question. For the Test My Genes, is everybody getting the same panel? Like, how is that working with the actual test?
Yeah, great question. So our genetic counseling team at the hospital decided on sort of a panel of common genes. So it's about 30. We use Natera Empower 38+2, which are the common ones. We don't go for the huge panels just because that really increases the risk of VUSs and genes we don't know a lot about. But I think some institutions use smaller panels. Natera was the organization that we had integrated the test ordering that we had integrated in our EMR, so it made the most sense. They were using it on the prenatal side. So
that's really, yeah, it's like Goldilocks and the Three Bears. You're trying to find the right panel for the right thing, and it's challenging. But my other question was regarding the providers listed a barrier being like, I just forgot to put the referral in because there's so much going on. Have you looked at all about kind of why the patient was being seen, like when they came to their visit, why were they being seen, or kind of the competitiveness of other health complications, and has that played in? I know it's preliminary, but I'm just curious to hear your thoughts.
It's a really great question. Like, what are the contextual factors? Like, we were told by one clinic, you can't implement right now because we just hit pediatric vaccine season, right? Like, we are too busy and that is taking all of our time, right? And so it's like, you got to think about when you implement something like this, even though it's maybe 4 minutes and 2 minutes on the provider side, what are they giving up to talk about this? I think the other thing though is that what we are doing is somebody could get identified, and if they keep coming back to the clinic, we re-notify the provider, hey, remember your patient, because it might not be the right time for the patient. It might not be the right time for the provider, right? And again, it's not, I mean, some people think of it as a one-time test. Not sure about that. The testing is evolving, so it may be that we are doing this test more than once, but it doesn't have to be done at that visit, right? But the idea is that we can capture them over time. So I hope that answered your question. But yeah, there's a lot of contextual factors that I think really impact the provider's ability to do that in the clinic in real time.
I had a question about training and capacity building that you mentioned a couple of times. And it seems like a lot of the work that's happening in training and capacity building is particular to each institution or an investigator that's taking on some initiative around improving genetic testing or precision-based approaches. And so I'm just curious if you have thoughts about other ways that we could improve training and capacity building, whether it's through primary care provider training or just generally that topic.
Yeah, no, it's a great question. I mean, I have to say in the last 5 years, I've been really happy to see questions about genetic testing on the board, like internal medicine boards and family medicine boards, because they start showing up there and then suddenly it's like, oh, we got to start teaching about this, right? I haven't seen it at a lot of our CME. I mean, I went to ACP. I think this year was the first year they had something around that. So I think we just need to see this start to make its way. And I think, leaders in this field we need to have our genetic counselors go in and talk in primary care about this and offer CME credit, right? I think the other way to do this is potentially to raise awareness among patients and have them come ask their doctor. There is nothing more motivating to me than when a patient asks me something and I'm like, I have no idea, right? I don't know. And suddenly I'm reading about it, I'm bringing myself up to speed, and I'm signing up for that session at CME. Right. So I think there's a lot of different ways that we can do this. I think that also what we found when we did our provider trainings is that it was easier to do the trainings at clinics where they had a staff meeting. So some of our clinics were small and they weren't having a meeting where they brought all their providers together. And that was a little bit of a struggle. We had to find a time to get everybody. So when there's a regular place that providers engage, to even go in and they actually, the providers gave us feedback that one 45-minute session and then coming back for some 15-minute little refreshers and talking about how to manage those patients was really helpful. So embedding it into the education and into the format of education that's happening for those providers anyway is another way to do this.
Thank you.
All right, thank you.